Okay, part 2 for chapter 16 has some terms that are important because we'll see these frequently throughout the neuro chapter, not only in this, but with our medical surgical text also. So when we're looking at the pathophysiology that goes along with our neuro problems, we're looking at the primary pathological mechanisms. Look at direct destruction caused by ischemia or hypoxia. So think about damage to the brain tissue, either from ischemia or hypoxia, so lack of oxygen basically to the brain, or that indirect destruction from compression. So think about a motor vehicular accident, something along those lines. Or number 2, the effects of toxins, chemicals, metabolic disorders on the brain. So think about bathing the brain in too much toxin or too much of a metabolic hormone that the brain shouldn't have. So those are usually where we'll see that direct or that the effect of toxins on the brain that lead to those pathophysiologies. Your book goes into a little bit about different lobular diseases. I don't want you to get bogged down by it, but I do want you to recognize some of the terms, especially that unilateral neglect, because we see this with a lot of our stroke patients, where they'll be aware of one side of their body but not aware of the other side of the body, so they tend to not pay attention to the other side, so it's more likely to be harmed. Literally, they'll hit it when they're getting in and out of bed. They'll let it bang against a chair, so they'll have damage or injury to a limb because they're not aware of that. So keeping that unilateral neglect in mind. And then it also goes into some of the neglect syndrome that would be more holistic of one's whole body instead of just a unilateral side. So be aware of that. And then when we're looking at the evaluation and treatment, so usually they're going to try to figure out why there's some sort of pathology. Is there something going on up here? Do we need to restore blood flow to the brain? Do we need to wait for the brain swelling to go down because of the compression? Is something building up in the brain so that we need to rid the brain of that? Think again about that mannitol, relieving some pressure there, because if we can figure out the cause and treat it, then we can hopefully reverse those factors that cause that pathophysiology within the brain. Note that if we can't fix it, so think about a stroke. If we've had a bleeding stroke and we're unable to fix that, then we're going to look at those rehabilitation things that look at how can we compensate or how can we restore them to the greatest independence possible. So not back to 100%, but how can we help them be as independent as possible when we're looking at those compensations. Again, don't get too bogged down with where this occurs, but do be familiar with these terms because you're likely to see them in EAQs and Hessian NCLEX. The agnosia, which is that inability to recognize shapes of objects. Remember in health assessment, I put something in your hand. I think we did a quarter, and with your eyes closed, you should be able to identify that at least it's a coin. Versus that aphasia, which is where we're have that impairment with comprehension or production of language. Two different things there. So impairment of understanding language or impairment with producing language. Those two are important that we understand. You can have one without the other. So let's go down to here. Read through this, understand the difference between the expressive aphasia, that's that inability to speak, but you understand, versus receptive aphasia, which is where you're talking, but it's nonsensical. It doesn't have any meaning. So you might see it as Wernicke's, which is the receptive, or Broca's, which is the expressive aphasia. So kind of interchangeable terms there. Broca's aphasia or expressive aphasia versus receptive aphasia and Wernicke's aphasia. Looking down here, don't get bogged down with this table, but do pay attention to these two particular types. They're the most predominant types that you're most likely to see. So that Broca's aphasia, that expressive aphasia, is that expressive aphasia where they can't find the words they're trying to say. So when you're working with someone who's had a stroke and it's affected a particular type of their brain, again, don't worry about where so much as what you're seeing symptomatically. They get very frustrated because they're not able to find the words to tell you how they're feeling. However, their comprehension is intact. This is one of those things where I hate it when I go into a hospital room and we've left the TV on something that is completely probably not wanted by that individual, and they can understand it, but they're not able to tell us that that's not what they want to watch or listen to. versus that receptive type, which is the Wernicke's aphasia. So they just talk, but it doesn't mean anything. They're not able to understand it. So be able to understand those two things. I think a lot of times when family members see someone that isn't able to find the words, they assume that they can't understand, but that's not the truth. That's not the case with this. So making sure that we're teaching that is important. And then I want to scroll down to where we talk about that your text calls it acute confusional states and delirium. Delirium is probably a little bit more common to what we usually how we usually refer to it, but your text also calls it that ACS, or acute confusional states, and it gives some of those conditions here that might cause those confusional states and delirium. Paying particularly attention to head, kidney, and liver failure. Think about when we were talking meds frequently, how an adverse effect with a lot of our medications were kidney function. So if I have a patient that doesn't have good kidney function, they're not able to excrete medications. When we have that buildup, it can cause delirium with quite a few of our medications. So looking at that patho with that, your book talks a little bit about what we might see if my patient's experiencing delirium, and I wanted to pull over to this. So some of my risk factors include some medications that we mentioned earlier: acute infection, sepsis, surgery, electrolytes, hypoxia, and metabolic disorders. And then look up here. We see delirium a lot in patients that are in critical care units after 24 hours because they're not able to tell if it's night or day. So many things are beeping. They have lost their sense of time. So that's a common occurrence when we call that ICU delirium. Going down to that treatment, we're going to try to first figure out why they're confused, why we're seeing this confused state, and then figure out if it's organic or functional, which is down here on this table, organic in the brain or functional if something caused it, and then try to see if we can fix the underlying reason why they've got it. If it's an organic state, we can't fix it, then it's something that's going to continue to get worse. So how do we work with that family and that patient? Good table 1612 on the comparison of delirium and dementia. Usually I think about delirium usually going away. We usually think of that getting better versus dementia, which is usually progressive, and it gets slowly declines. It gets worse on that with that individual. So there's a big difference between that delirium and dementia. Your book goes a little bit about in the dementia and differentiating it out, and this is where I want to go back to two things in our lesson. So from here to the end of the chapter, the book does a good job of separating the different types of neurological disorders basically into 4 different types. So I'm going to pop back up to here, and we have lessons on these. Parkinson's, Alzheimer's, seizures, and ALS, and I did them like that in order. If I were going to tell you to spend some time looking at these as far as what we see most commonly, start with your Parkinson's. We experience that more frequently in the acute care setting. You're going to see that. Remember how many of our medications we talked about with Parkinson's disease. Next, spend some time with Alzheimer's, talking about that. We might see Alzheimer's in the acute care setting, especially if they're having exacerbations with their Alzheimer's or if they have a comorbidity. So say I have an Alzheimer's patient that also has a heart attack, then I might see them in the acute care setting versus a long-term care facility. So think about when I might see that individual in the acute care setting. Then thirdly, I would tell you to go to seizures, because we will see seizure activity, but not at the same rate as our Parkinson's and Alzheimer's. And then thirdly, you can look at that ALS and work through those lessons. So if you kind of do these synergistically, like pop through the textbook and read about it, and then go over here and look at the lesson, I thought that was pretty helpful way to work through that those scenarios. And then I wanted to take us to over here. Think Like a Nurse, which is something that I used a little bit last semester, not a whole bunch of pharmacology. So in this scenario, we're looking at an individual with delirium. So on this one, we have acute delirium. Remember we said last week in class, acute versus chronic, and often we can have somebody that has a chronic issue that has an acute exacerbation. So with this one, we're having someone that normally doesn't have delirium, but shows up with an acute set of delirium. So I have uploaded this PowerPoint in our in our course for under this week too, and then I've also got the answers that are going to open up at 3 o'clock on Wednesday, so when we would traditionally have class. So if you have any time beforehand, you want to try to work through it, that would kind of get you set up for what the answers actually are for that. So I think that'll walk us through this chapter pretty good. I'll be able to answer any questions that you have on 2-1. Thanks, guys.